I want to invite you for this outline. I would like to do a little work on the past, present, and future of primary care. I also would like to share with you some experiences in continuous quality improvement programs, what's going on in the real life, what it means, complexity, clinical inertia, safety, elderly, and also the concept of personalized care and about the future. So primary care, I think, according to different healthcare services in the different countries, we are managing primary care, or we are understanding primary care from different angles. And I think I'm just providing here the example of my country in Spain, when we start working in that approach in primary care in early 80s, and before that, it was just considered not primary care as a specialty, it was general medicine. And then we also have to move to this new era where we have to be moving more for a primary care and community specialization. That is what we are having now. So this, as I said before, there are very many differences between countries because it's how they are providing care, and it's like based in a public health providing, or is maybe moved to the private system. So it's different realities. But in Spain, we move in that reality, and in the middle of 80s, we changed from a reactive approach to more proactive approach. I think this proactive approach, it was an approach where the person and the patient was in the center, and all the other professionals were around that person, trying to provide the best approach possible. So a primary healthcare team is like this composition in Spain, as you see, the social worker, dental care, health technician, administrative personnel, but mainly this unit, the GP or the pediatrician and nurse as a team providing care to the citizen. I think that we have different examples, and we have also, there are rural and urban centers. We start working in protocols, and also we start developing some first quality improvement programs. The first one in hypertension and diabetes in the middle of 80s, as I said. And I think that always that has been still at that moment, under an hospitalized center perspective. So we've been, because by tradition, our healthcare system is really based on the hospital's service and delivery. And we try to move from that perspective to a more primary care oriented providing of care. So at the beginning of 90s, we start with the primary prevention and healthcare programs. And that one's starting, as I said before, hypertension, diabetes, osteoporosis, COPD, asthma, depression. And I think that if we move to the diabetes field, I think that in primary care, we have many challenges. We know that around 50% of our citizens with diabetes are undiagnosed. And we know that for different population-based studies, also ones done in Spain in the 2012 and published in Diabetologia. Also, we know that before diagnosis, we know that it's already a diabetes onset of around 7 to 12 years. And then it's important that probably in that period of time, maybe from primary care, we can, develop some kind of strategies that be more proactive in terms to detect those persons with a higher risk of that. We know also when we diagnose a person with diabetes, we know that almost 25%, they already have microvascular complications at diagnosis. I think it's important to also to know what is the value of the different tests we have available. There's a lot of work done on that. There are different tests that allow to understand if these tests could be feasible and also could be validated in different countries, and what is how useful are that tests in our settings in terms to be used in a normal practice. But also I think it's very important to be very focused at the risk population, those ones that we know they are going to probably develop diabetes. And I think that here, all patients with cardiovascular disease, all of these ones with BMI over 30, when you have family history of diabetes, some ethnicities have a higher risk and at certain ages. And we know that some persons that have a previous, IGT or maybe gestational diabetes, or those subjects, those persons with a higher risk to have the disease. So if we follow the cornerstones of primary care suggested by WONCA, we know, and the WONCA is the World Organization in Primary Care, we know that it's important to be providing an holistic modeling, an holistic approach, person-centered care. And I think when we try to be with a community orientation, but I think that following that approach, what we can offer from primary care to our persons is probably a better campaigns, a better ways to identify and screen those persons with a high risk of diabetes. Also trying to implement those methods to decrease complications, probably have good programs that trying to, and validated programs, lifestyle that promote lifestyle changes, behavioral changes. And I think this is really crucial. Also, access to medications, and have all health professionals have good knowledge on how the medications works and probably how we have to use it properly in clinical practice. And I think that, of course, and also we have to develop those strategies that allow us to coach those persons with chronic diseases to a better understanding and also living with a chronic condition. For that, I think it's important probably that from late 90s and beginning of the 2000, we have different programs. So we start having more access to electronic clinical records, and that allow to have electronic clinical records and also guidelines implemented electronically. And I think that examples here from the UK and from Spain, where they try to implement in that electronic clinical records the QOF, or maybe in Spain, trying to implement continuous quality improvement programs, where we try to assess process and intermediate indicators, were successful and demonstrate that when we try to coach and to support electronically our healthcare professionals, they are paying more attention because they have systems that pop up and assist them and coach them in terms of their management of their patients. An example is that one that has been published in 2017 from my country, when we try to implement the actual guidelines that we are using in Catalonia inside the electronic clinical record, that goes with an improvement in different aspects. Here you have the different guidelines implemented, and non-user and user of that guidelines shows an improvement of the different indicators we try to assess on that pre and post control study. So it's clear that we have tools that support and coach healthcare professionals, nurses, GPs, those ones managing the chronic conditions, that can be useful in terms of understanding and managing and coaching patients without chronic conditions. So I think it's important that when we are in that situation, we establish a continued quality of care standards. We also establish some other kind of tools that we can use it in this situation that allow us to, and also clinicians to understand in terms of safety, in terms of contradictions advice, and that has been introduced in our clinical records. But I mean, what is going on in real life? What's happening in our real life? And I think it's, we know that we have to face in primary care to more complexity. We have persons with more chronic conditions, and it's also increased the complexity of management of the persons. And I think if we follow that scheme suggested also Wonka by Wagner many years ago, I think it's important to know that we have to put all the different efforts trying to collaborate and coordinate our delivery and put the patient together with a good connection with the patient and the healthcare system. As an example of what challenges, actual challenges we have in the primary care in diabetes, we have to face with complexity. This is a very well-known figure when we see that diabetic persons have at least, when they have over 65 years old, 6.5 or more other chronic conditions. So it means that we are not just having to take care of diabetes, we have to take care of other things. Another concept is clinical inertia. We know, and this is a scheme we have here, when we are starting using, for example, insulin in primary care, and it's clear that we are delaying, and this is the first figure we have, time to insulin initiation between, in some countries, between 2 to 4 years. For example, in the UK, you see between 4.7 to 5.6. And there's a delay and a clinical inertia. And when you see in the other figure, what is the value of A1C when we start considering insulinization, you see that we are a lot far when we could be ideal. We are over 8, in the UK, you see values around 9.4. This is also observed in other countries like Catalonia and Spain. Here, for example, I showed you the data published in Catalonia, when you see that when we start in, or we considering, and this is a data from all the Catalonian primary care centers and all the citizens with diabetes in the primary care system. And you see that this is more than 300,000. And you see here that when we are considering to start insulinization with a values of A1C above 9. So I think this is a lot of space of improvement on that. So clinical inertia is also known by this study that could be in that kind of design, we can correlate if this clinical inertia can emerge, can drive to an increased risk of complications. And this is important concept to keep in mind, because when you know that you have clinical inertia, you are delaying intensification, but that could have consequences. That is really important. It's a very strong message to keep in mind that you have to do something else. You have to do some action. This is a figure that has been presented last week at the ADA. This is a summary of all the studies running, already some of them published, but that introduced the concerns about safety. And also the benefits of some of these compounds are showing in terms of managing the diabetes. So I think it's important that safety is something that can be considered, but cannot be a barrier in terms to intensifying therapies. And these studies are showing that the majority of compounds we are using now, the new compounds for diabetes, injectables and non-injectables, are safe. And some of them also goes with some additional benefits. And this is also translated into the new guidelines and recommendations. Another thing to consider is in terms of aging, in terms of age. We are managing majority of our patients in our countries are older adults, and that it means that the prevalence of diabetes on that persons is of course higher, and could be around 25% or higher in persons above 70 to 75 years old. That it means that a quarter of patients we are visiting of that range age have diabetes. And when we try to intensify the benefit, we can observe it when you are treating patients at that age compared with those young persons is very different. So it means that the benefit we can obtain in that ages in terms of intensifying therapy is less than what we can observe in youngs. So we reserve here, we move back, or we put the message in the other side. Here, it's important to identify young persons with this chronic condition and be very tight at the early phases of the disease, because it's when we are going to observe more benefit. Another concept is frailty. Frailty, and that has been described in some international recommendations, like those ones moved by the gerontologists, like, for example, Alan Sinclair and his team, and also with other guidelines. Also, the Primary Care Diabetes Europe, my group, also suggests a position statement on that. And I think frailty must be assessed in our elderly patients, because when you have frailty detected, the targets you have to consider for those persons must be different. It's different approach. Also, what happens with the kidney? And this is in a study published in Spain, and what is the prevalence of kidney disease? And I think we are testing sometimes A1C, other parameters, as for example, eGFR, kidney function, or maybe urine albumin ratio, where we can observe the damage in the kidney. But sometimes we are just testing and not reacting. And I think it's important that the prevalence of these chronic conditions and this damage in the kidney or diabetes kidney disease is more high than we expect. And I think it's important when we have this kind of observations to try to provide an approach, a different approach, and the adjusted approach to that kind of observations. So again, this is a very strong message. We have to put the citizen, the person with the chronic condition, in the center. And we as a healthcare providers, we have to understand what is around that situation and how we have to manage, how we have to understand the situation, how we have to do the different approaches, how we have to agree in a plan, how we have to share with the patient our goals, and then the patient also must be involved, moving far from a paternalistic approach, implementing and also coordinating with the patient, or just adjusting for the different realities, this trajectory of the diabetes disease management. This is a figure that you know perfectly, is the last ADA ESD recommendation. And I think just this is my last messages. I think it's important to know that nowadays we are providing care. And I think it's very important that when we are providing recommendations, advice, or care, we have to provide that kind of products, that kind of activities that have evidence supporting behind. And I think that programs like in Spain, the patient expert patient, or in the UK that has been validated, the expert patient program, the Desmond program is an educational program implemented and built in the Leicester University and the Leicester Diabetes Center that has been implemented around UK. I think it's important initiatives that we have to consider, because we don't have to invent anything. Maybe we have to adjust, we have to validate in our country, but we have to do it. We have to forward some initiatives that already are very robust and they are bringing with good value behind. Also, there are many different initiatives in many countries, and also in your country, in India, about diabetes prevention. It's important. It is an initiative, and we know that the initiative works. We have to follow. It's not just that it has been published in a paper, but when something it works, we have to be committed to be implementing that initiative, that thing that we know it works. And I think that we have to take care about how primary care agenda and endo and diabetology agenda have a similar roadmap, a similar trajectory, trying to put all the force together to try to be centered on our patient-centered approach and trying to provide the best care possible. I think that now we are living in a digital life. We know that because this pandemic has shown how important has been digital life to be living, and also I think there's no other excuses to implement digital solutions in the real life. So I think that in terms of education, monitoring, etc., education, digitalization is here. It's not a dream. It's here, and we have to investigate. We have to implement that solutions in real life as much as possible. I think also that is important to consider how we are doing benchmark of that initiatives, how we are benchmarking the best practices, and how we are understanding and how we are learning from that best practices. So it's important to have this personalized approach. So as I said at the beginning, I prefer to be more solid in a positive message, not fixing on the ground what is in the I would like to move to the challenges, to that opportunities we can consider to improve. So as a summary of my presentation, it's clear that type 2 diabetes management is a priority in primary care. I think that is an important impact of the continuous quality improvements in the UK, in Spain, and in other countries, okay, and electronically implemented. I think that concepts as complexity, personalized care, safety, clinical inertia could be considered as barriers in terms of primary care clinical practice. We have to identify, we have to coach our colleagues to allow them to understand that ones and to take that ones as an opportunity to learn and to improve, okay? Not as a barrier, not as something that keep us like stable and not reacting. And I think it's important that we have to create a balance between diabetes complexity and the care we are providing. We have now a lot of tools that allow to understand or let us know, allow us to identify the complexity of the patients we have in front of us. We have to provide the care adjusted to complexity. We have to provide a strong, probably, approach to those persons at the early situation of diabetes, young persons, and we have to provide another approach completely different with elderly, with older adults with diabetes. We have to abandon. We have to provide the approach, the appropriate one, with the appropriate benefits we know that are behind that approaches. And also, and my last message is implementing technology, using technology to support in this new era where we are now trying to manage and to coach persons with diabetes from the primary care field. And this is my last message. Thank you for listening.
Excellent presentation, Dr. Xaviers. I fully agree with you that diabetes has to be managed well at the primary care level, because the first few years a diabetes person spends with the family practitioner or the primary care providers. And if they treat the disease well, aggressively, I think most of the job is done, because the complications set in very early. You rightly said that the inertia needs to be addressed and the importance of the EMR. Now the session is open for the questions. I'll start with the one. Has the pandemic of COVID changed the way you practice in terms of the digital platform use or in the terms of the medications that you use?
Not in the I mean, the COVID pandemic also brings some alerts in terms of you are in the sick days. The concept of sick days sometimes require some update in clinicians because they are not really aware about what it means sick days and what are the medications that probably require maybe to be stopped or to be down titrated or maybe some coaching for patients. I mean, if you are on insulin and you are on SGLT2 inhibitors and or you are in SUs, probably if you are in sick days, you are reducing your carbs intake or something is important, some messages, important points of education we have to be understanding for the next spread or for whatever. But I mean, 6 days, I think is an important concept to review and to keep all of our colleagues updated, healthcare professionals, nurses, GPs, etc. In terms of digitalization, of course, I mean, we are not controlling our patients in primary care. The centers were closed, everything was closed. Imagine, and I've seen now in clinic, these first 2 weeks, I've been doing clinic twice a week. I've been very surprised about the consequences of COVID in some specific persons. I've seen, and this is very rare, diabetic foot ulcers in 3 patients that they were not consulting because they were scared about the COVID and they were delaying and they had that problems for more than 1 month. It was in this period of alarm and that could be consequences. So it will be important to probably to identify and to understand what happens during the COVID pandemic, what has been the problems of the consequences, and probably for the next phases, probably more prepared, aware, and informing the citizens what are the reasons to call the center and to come to the center. But now we have been in a very, like an under of earthquake of information, a lot of contradictories, a lot of uncertainties, and I think it's an area we have to explore in the next weeks and months.
True, very true. Rutul, do we have any other question?
Sanjeev bhai.
Yes.
Yes, Francis,
Yes,
fantastic talk.
Yes, wonderful talk and very important too, because he rightly pointed out that diabetes has to be managed very well at the primary care level, which does not happen in our country.
Yes,
so I think more and more work needs to be done in that direction.
And that's the reason, you know, we had collaborated with Primary Care Diabetes Europe.
Yes.
And we will be having one big meeting with PCD. And I'm a big fan of PCD actually, and Francis is a close friend of mine. I just wanted that how often in primary care in Europe they use GLP-1. The uses of GLP-1 at our primary care level is very low.
Mm-hmm. Yeah. So, yeah, that's true. That's true. I mean, on the figures we have, for example, in Catalonia, is we are using GLP-1 receptor agonists and the injectables because we don't have the oral one already. We are using below 2%. Okay, in the total amount of type 2 diabetic persons. And if we go, for example, for one of the restrictions, it will be BMI, and we consider, for example, BMI of 35, for example, that is not our label. Label it says, because so many countries are putting conditions in terms of reimbursement, and they're saying that if you are not above 30 on BMI, you cannot, this medication is not reimbursed. Other countries say 35. But if we know and look at what is the BMI, the average BMI of citizens with type 2, or the percentage with BMIs above 30 or 35 is around 50 or 60%. So it's clear that primary care physicians and also endocrinologists are not really using this compound, this injectable in the real life. I think that now it seems that there's more movements to do that, but there's a lot of, sometimes I think, reluctancy to use that compound, sometimes in terms of cost, because some countries have cost control in healthcare providers, but in other countries it's because they are feel a little scared about using an injectable because they still don't understand well how this compound works. So it's a lot of education needed, and also put in place what are the benefits of that medications compared for other injectables, for example, of course, insulin, or maybe other orals that are not having these benefits in terms of complications. An example is there's a high use of incretins in terms of DPP-4 inhibitors around. And of course, we know they are very safe, but we know that at the same time they are safe, they are not having, I mean, potential benefits on some cardiovascular or other sides, complications. No? So I think that, of course, put in place what is shown on the different cardiovascular outcome trials and just revisiting what on the latest recommendations, as for example, the latest version of the latest position statement published 2 weeks ago from PCDE, it will be a good exercise to do to know how we can understand how useful could be these different compounds in terms to be introduced in clinical practice.
True.
Sorry,
I think we are coming to the end of the session. Thank you very much, Dr. Francis.
Thank you very much.
And we look forward to meeting you personally once all these COVID things go away. And we wish and we pray for that.
Sanjeev, you remember last time when we were in the Barcelona, only he suggested and he guided us where to go.
Oh, yes. So we enjoyed Barcelona very much.
Francis, now see you in the PCD symposia.
Okay.
There. Come on. See you.
Come on. Okay. Bye-bye. Talk to you later. Thank you very much.
Thank you.
Thank you.
Dharmendra, you take over.
Next session would like to request Dr. Rutul Thakkar to invite over the next speaker. Dr. Rutul Thakkar, over to you.
Thank you very much, Dr. Ravinder. We have next speaker is Dr. Leszek from Poland. Leszek Kutrianik was a specialist in internal medicine, specialist in diabetology, head of Department of Diabetology and Internal Disease at Medical University of Warsaw, Poland. He graduated from Medical University of Lodz in 1994. He held foreign training and scientific internship at Oxford, London, and Wakefield in Great Britain, and also in Miami. In his clinical practice, he focuses on diagnosis of carbohydrate tolerance disorders and the treatment of type 1 diabetes, type 2 diabetes, and diabetes accompanying other disease and complications of chronic disease, primarily circulatory system, nervous system, and eye organ. And so many in EAFE, he's postgraduate program director in EAFE. So I hand over to Dr. Leszek for his next session.
Okay, thank you very much. I hope you can hear me. I'm happy to join you for today's session. Yesterday was great. I spent almost whole day listening to the sessions and lectures. So my congratulations to the organizers, to Dr. Sabu first of all. And I'm happy to join you again and to talk briefly on the subject, which is actually one of the hottest one, and it will be very heatedly debated in the next few months, I believe. So I was asked to answer the question, are all SGLT2 inhibitors the same? And today is this answer easier than it would have been a week or 10 days before, because we've just had the results of Verity study at the ADA meeting. We all know them. I will briefly touch them because they are quite important for answering this question. But let's start with a very general look at this group of drugs. So SGLT2 inhibitors are a unique drug group, similar like GLP-1 receptor agonists, because we are not using it just for metabolic control. In fact, we can look at all of them from 4 different angles. We can look at them whether they are okay or similar or the same in terms of achieving metabolic control. What is their effect on cardiovascular risk? What is their effect on renal risk? And what is their safety? Are they different in terms of safety? This cardiovascular risk and renal risk are 2 sides of the same coin. because it's a macro. We talk about macrovascular complications with cardiovascular risk and microvascular complications. And these are the first drugs ever. GLP-1 receptor agonists came a few months later with the results, but EMPAREG outcome study showed that we are able to treat diabetes and affect all spectrum of diabetic complications. We know little about retinopathy and the effect of these drugs on retinopathy because simply it wasn't studied well enough. But we know a lot about kidneys and we know a lot about cardiovascular system. So when we talk about similarities and differences between these agents, we have to at least look at from these four perspectives. Are they similar or are they different? And I will come back to it at the end of my presentation. These are the four agents which are available worldwide and used most often. The first one which was introduced in Europe was dapagliflozin. The first one which was introduced in US was canagliflozin. Empagliflozin was put on the scene thanks to EMPAREG outcome, and ertugliflozin is one of the most recent additions to this group. And if you look at the chemical structure, the differences are actually little. We are all not biochemists, but if you read a little bit about biochemistry, the differences are here on the right end of these chains, but they are not very strong. So if we think about the differences in different studies, it's hard to attribute them to the molecules, at least to their chemical structure. If we look at more pharmacokinetic data, they are also pretty similar, because if you look here at the protein binding rate, for example, at the bioavailability, at the time to achieve maximum concentration and a half-life time, it's more or less the same. The differences are no greater than 20% between each drug. What is different though, and this is one of the backgrounds for the discussion why in the studies we saw differences, is the SGLT2 selectivity, because canagliflozin is different here than empagliflozin, and empagliflozin is actually the most selective agent. So maybe this plays the role. It's just a hypothesis, but again, ertugliflozin is very similar to empagliflozin in that regard. It's also similar in terms of protein binding. It's similar in achieving maximum concentration. It's very similar in its half-time, and also the concentrations are close. So not much differences if we look at the structures of the biochemical data. Interestingly, if we compared it to DPP-4 inhibitors, they are much more different if we look at the molecule structure. Each DPP-4 inhibitor was actually discovered or invented from a different chemical group. They come from amino acids, they come from organic acids, from different, the structures is really, really different. Still, they block DPP-4. Here, we have much more similarity in terms of biochemical structure. So what do the recommendations say? Are they any different or are they all the same? If you look at the latest edition published in December last year, 6 months ago, of the ADASD statement, SGLT2s are mentioned here on the left, and they are not, they are used as a whole group in this algorithm, but here at the bottom, and I enlarge it, some of them are mentioned. It's all, of course, due to the studies which results were available before publication of this algorithm. So in December, we have clear statement that canagliflozin has very good renal data and dapagliflozin has heart failure data, but it's only because we have separate studies analyzing these drugs in heart failure or renal failure patients. More studies for each of the molecule will come in the next couple of years. And then, so if we look at this page here, not much differences really. More similarities, and SGLT2s are really treated as a one group. And then the Veritas trial studies arrived only on Tuesday, so it's not even a week ago. And just briefly through main results, if any of you haven't heard about them, the patients who were included in the study were almost exactly the same like the ones which took part in EMPERG outcome study. 3/4 had cardiovascular artery disease, almost half had myocardial infarctions, and this figure is just identical for EMPERG outcome. It was less than in EMPERG outcome. There was about 25% here, 20% patients who had a stroke, and there is a larger proportion of patients with heart failure or renal failure, for that matter, in this group. So this was really diabetes at an advanced stage patients who really presented with complications. 100% of them had coronary artery disease. And this was this surprise, as we said already yesterday, when we commented these results together with Per Henrik Group. There was no change in the risk of MACE, so cardiovascular death and non-fatal stroke or MI. Of course, the study, and this is one thing which is always worth remembering when we talk about cardiovascular outcome trials, that the drugs which are used in the studies and are studied are used in a, let's say, unphysiological way, because the patients in all CVOT trials were treated normally as they would be treated if they were outside the trial, and they had just drug being given as an addition, drug or a placebo. So no doctor gave an agent to achieve anything, and we don't work this way. We always prescribe drugs because we want to lower blood pressure, blood glucose, improve symptoms, alleviate pain, and so on. Here, the patients were just getting the drug, and the reason for this was that they were really safety studies, not any treat to target or not to achieve anything, just to see if the drug is not harmful. But because of the results of earlier studies, our appetite rose significantly, and we would expect to have the results here exactly like in EMPERG outcome. However, no difference in MACE, even less difference in cardiovascular death, expected improvement in the risk for hospitalization of heart failure, 30% decrease, and also somewhat the commentaries up to today, what I heard is just that, well, the people say, well, it works on kidneys, but somehow weaker than, well, canagliflozin or empagliflozin. This is the renal composite endpoint. Statistically did not achieve statistical significance, but if we look at the curves here, eritugliflozin did slow down the decrease in eGFR. So there is some renal effect, but maybe less pronounced than in case of other SGLT2s. So here we start to see also some differences. So this is a summary of Verity's study. The only clear effect in terms of outcomes was the impact on heart failure hospitalization. Statistically looking, all other endpoints were just neutral. There was neither improvement or worsening. So how it looks now we can compare 4 main SGLT2 inhibitors looking through the lens of the results of CVOTs. If you look at the baseline characteristics of patients, they were actually pretty similar. Look at the age, it was 63 on average. Amazingly, any randomized trial, any large randomized trial, is it CVOT or not, which is published, they always recruit on average patients being 62 or 63 years of age. So when I have a patient who's 77, I'm not sure if I can translate these results directly to this patient. And also if I have a patient who's 42, it's probably a little bit different. Female were in minority, about a third. Glucose control was very similar at baseline, 8.1 to 8.3. And different agents, although the assumption was that there will be no differences in HbA1c, there was a slight decrease in the active treatment arm. With Verity's, it was quite a clear half of a percentage point of HbA1c decrease in the patients receiving eritugliflozin. If we look at this is where the differences were. The established cardiovascular disease, 100% of patients had it in empagliflozin study and eritugliflozin study, and as we know in DECLARE, the population was the healthiest. Also, the percentage of patients with heart failure was the highest in erythrogliflozin. And again, that's intriguing because the worse the health condition of the patient, the greater improvement in risk if we use any drug. That is the way it usually works. That's the way why statins are so effective in diabetes patients, more effective than in people without diabetes, because the baseline risk is greater. And also patients with reduced kidney function, as you can see, the percentage of patients was different, although Credence study was dedicated to these patients, so no wonder it's 60% of patients had eGFR below 60. What was also different, that it may be discussed whether it is relevant for the results or not, was the duration of the studies. Because if you compare Canvas and Declare, this is almost twofold difference. It was over 4 years here, less than 2.5 years here. But again, the most compared studies today, EMPERAG Outcome and VERTIS, had exactly the same duration. So look at just to see the differences and similarities briefly through the main endpoints. If you look at MACE, Credence, EMPERAG Outcome, and Canvas showed significant reduction. Declare and VERTIS failed to do so. If we divide the patients at baseline, whether they had that of atherosclerotic cardiovascular disease or just risk factors here, the effect is more clear in patients with atherosclerotic cardiovascular disease, less clear apart from Credence study in patients with risk factors. Cardiovascular death is the variable where the differences are the greatest. Here, clearly, empagliflozin is an outstanding agent, outstanding in both meanings, you might say, where it reduced cardiovascular death by almost 40%, which is a spectacular result. In other studies, we had just a borderline reduction in the Credence study, but they were renal patients. The other typical cardiovascular outcome trials like EMPERAG Outcome showed no effect on cardiovascular death. And this is very clear if you look at the figures. We have early separation of curves in EMPERAG Outcome, and this was explained because it is still not clear. Even Boehringer cannot really say, although they produce the drug, why there is a risk in cardiovascular death here. What is the clear mechanism? And the main explanation was, well, the drug is very effective in improving heart failure. People just don't go to hospital with heart failure. And we know with patients with chronic heart failure that at some point, this second, third, or 10th hospitalization for heart failure ends with a patient demise. So if they don't go to hospital, they are less likely to die. That sounds logical. But we had the same in the VERTIS study, and you can see superimposable curves here. So heart failure, this is where similarities are the greatest. And if we talk about class effect, it's clearly a class effect, this diuretic sodium sparing mechanism, and probably something else, maybe ketone body production, maybe glucagon rise, it all contributes to help the failing heart, whichever SGLT2 inhibitor you use. Again, if we look at the figures, these differences are the similarities are very clear, that placebo and active treatment group are always different here. But just look at those two figures. VERTIS showed very nice and very early separation of these curves for heart failure hospitalization, even greater than EMPERAG Outcome, and in cardiovascular death, no effect here. This is really a puzzling thing. And when yesterday we tried to discuss it with Ralph DeFronzo, he also didn't have any good answer. With renal effect, we would say, before VERTIS study were published, that, yeah, it's also the class effect. All SGLT2s reduce the progression of chronic kidney disease, but this erythrogliflozin drug somehow does it in a more slowly way. So if you look at the figures here, just coming to an end, we can see a clear similarities in terms of heart failure and less similarities in other elements. And finally, if we look at safety, this was the fourth variable I mentioned at the beginning we should look at. Here, those main worries, the greatest worries like amputation, fracture, or diabetic ketoacidosis, events of special interest, they're actually very similar across all the drugs. And the main side effect, which are genital mycotic infections, are also very similar across the board. Interestingly, ertugliflozin in earlier studies showed a little lower frequency incidence of genital infections than the other agents, but in general, they all are associated with the same risk of developing mycotic vaginitis or balanitis. So when the Verity studies were presented, this was the list of questions trying to answer why the differences we see in this cardiovascular death risk, what might be the cause? Is it the specificity, as I showed you here? Possible, but there is very little difference between EMPA and ertugliflozin here. Is it differences in populations? Again, very little differences in those two drugs, showing greatest differences in the results. Is it the study design? Is it the way the endpoints were collected? Cardiovascular death is a cardiovascular death. It's very difficult to misdiagnose it, at least at a large extent, maybe a few cases. Differences in comorbidity management, that's pretty possible, but then we do not have any more data. The data here was not shown. So just to summarize, are they all the same? If we look at metabolic control, I didn't discuss it here, but the power to lower blood glucose, we know it's more or less the same. If you happen to switch between SGLT2 inhibitors, which anecdotally, I happen to switch it between the patients, not because of mycotic infections, but the patient was saying, well, I pee a lot on this drug, and I heard that on the other one I would pee less, I just switched them. And for glucose control, there was no difference at all. And the effect, although we do not have head-to-head studies here, the effect is really similar. In cardiovascular risk death, we equal sign in heart failure, not really equal in cardiovascular death. In renal risk, it's more or less similar. We may discuss the differences in the power to decrease the increasing deficit in eGFR, but the action is in the same direction and safety is similar. So if we look impartially here, we would see more of these signs here. We would see more similarities, in fact, than differences. So if I wanted to put it in words, in some conclusion, I would say that, well, they are not identical. They are different molecules. So there is no, although with little differences, but sometimes the little difference does matter. But they are not identical, and there is no overall class effect here. Yesterday, Per-Henry Group used the comparison that a car is a class, but there are different cars in this class, and perhaps that might be the case, but we don't know what are the engines, what are the mechanisms that these cars are driving at a different speed and achieving different results. So I believe that it's difficult to say that across the whole spectrum of the non-glucose lowering actions, there is an overall class effect. So there are differences here. Glucose lowering, that's fine. So as long as we use these drugs just to lower blood glucose, it doesn't really matter which one we would choose. The effect will be the same. But we somehow look at these drugs just a little like the typical anti-diabetic drugs. We expect much more now. So their efficacy is similar in reducing heart failure risk, is more varied in reducing chronic kidney disease risk, and is definitely different in reducing cardiovascular mortality. And despite many studies which have been conducted already, we will need many more to understand these differences. Thank you very much for your attention.
Well, excellent presentation. Congratulations and thank you, Dr. Leszek, present from Poland. Well, that brings us down to one question again. That amongst the 4 cars that you mentioned, BMW, Mercedes, Audi, and Volvo, or maybe empagliflozin, dapagliflozin, Kena, and now R2. If you have a patient who is 60 years of age, has established cardiovascular disease, but no CKD, which SGLT2 you will choose? Another scenario, CVD yes, CKD also present, then which one? In absence of CVD, If CKD is there, which would be the ideal one? And if patient does not have CKD or CVD, which should be the agent of choice? So 4 different scenarios.
Okay. It seems that the answers might be difficult, but actually the answer is pretty simple. If you look at the total net benefit of any SGLT2 inhibitor, clearly empagliflozin is #1, and it's hard to argue with that. If we have because of cardiovascular death risk reduction, if I don't know what to do with the patient who's sitting in front of me, I'm always thinking, well, if it was my mother or father, more often nowadays, I rather think if it was my brother or sister when I get older, or even my son or daughter, unfortunately. So why should I prescribe a drug which does not reduce cardiovascular mortality, is also effective on also has renal effects? On the other hand, if we have patients without any cardiovascular disease or any vascular complications, you might say, well, okay, then it doesn't matter. But again, we already have analysis, and there were plenty of them presented at the ADA, that empagliflozin again is effective in patients with risk factors, similarly to dapagliflozin. So it's also here in risk factors patients, they are quite similar. If the kidney is a pronounced problem, this is the greatest problem. Of course, canagliflozin has the best data. But again, all these drugs are probably similar in kidney risk reduction. From a patient perspective, I once had a patient who was a doctor, a surgeon. And when he asked me exactly the same question, he asked me, okay, we have in Poland, we already had 4 agents for all of them. And it was before Verity study, of course. And he said, look, which drug you're going to prescribe to me? Ertugliflozin has no CVOT study published, but the others 3 have. Which one are you going to prescribe to me? And I said, well, probably I should prescribe again empagliflozin because it reduces cardiovascular death. And he said, exactly. I would expect you to prescribe me the drug which will reduce the risk of me dying. So we might be asked by patients, why did you give me, I know, Cana or ertugliflozin and not EMPA, while this EMPA protects me from death? So we will see Boehringer getting more and more important, having more and more money and spending more and more money, because it's really difficult to match their achievements. On the other hand, we still should not remember, we should not forget that they are just good anti-diabetes drugs. This is purely from medical perspective, but there is one other thing which we have to look at when we prescribe those newer agents, and this is the price. And I guess the only way, for example, for ertugliflozin to stay on the market would be to offer a very low or much lower price than the other agents. And then if a patient cannot afford EMPA or DAPA or Cana, but could afford ertugliflozin, and that would be the only SGLT2 to prescribe, then okay, go for it. Of course, still it will have plenty of benefits, because as I showed, really there are more similarities than differences, but there is no class effect. Also, the reimbursement issues, which is, I guess, less of the issue in India, but in other countries, we have DAPA, EMPA, and Cana reimbursed for patients with cardiovascular disease before insulin initiation on 2 oral agents with HbA1c over 8%. So it's a complicated prescription for reimbursement, but the government said, okay, instead of, if someone is on 2 oral agents, 8% of HbA1c, if you want to improve it, you would probably move to insulin. Insulin is reimbursed, it's expensive, so we can spend the money instead of insulin, we can spend on SGLT2s, and we have them reimbursed since November. So there are 3 issues. Patient profile 1, the second is the money, the third reimbursement policy, if it applies to any country. And if I'm still saying anything, I would just say, I like to say to Sanjay and to Bridge, whom I know quite well, especially Sanjay Kalra, where we worked on a few papers, and I'm always delighted to see more friendly faces from India on the screen, because Banshi is every time here, so I can't greet him at every occasion, but I'm happy to see others too.
Very much.
So Sanjay, your comment also on the same, and somebody had asked in the question answer chat box also regarding the Remo, and I would also like to have Krishna comment, where he just before some time he debated that now CVOT is not to be done for all anti-diabetic.
I agree with what Dr. Leshek has said. First of all, Dr. Leshek, a warm welcome to India. We are happy to have you with us. I would echo what Dr. Leshek's physician-patient said. What would you prescribe to me? What would you prescribe to yourself? And if there is one drug which has proof versus another which does not have, then what would you choose? We've been talking about hyperglycemia, and Dr. Leshek talked about different types of cars. This month, Dr. Leshek, in North India, it is the mango season. So there are different types of mangoes. We have so many varieties. Now, every mango is different. You cannot compare Alfonso with Langda. So similarly, you cannot compare different gliflozins or different DPP-4s or different insulins with each other. So the data is there, the CVOTs are there. If tomorrow CVOTs are not done for a new drug, that's a separate matter. But today we have the data and we should follow that.
So Sanjay, in your words, which one is Alfonso and which one is Langda?
Both are tasty. Depends upon what you want. Depends upon what the patient wants.
Okay.
If your patient wants only glucometabolic relief, you have a choice. But if your patient wants vasculometabolic safety and benefit, wants viscerometabolic safety and benefit, then you have to go and search the data. Which gliflozin is it which actually improves cardiac health, renal health, maybe hepatic health, and then we choose accordingly. So it depends upon the taste that is required.
And for Indian perspective, at half the cost, because half the dose also is effective with EMPA.
Indian lives, Dr. Saab, are as expensive and as precious as Polish lives. Exactly the same. A life is a life.
Thank you very much for this comparison with mango. Poland is famous for apples. We are one of the largest apple exporters, and the apple season will soon start. So we would rather compare that apple is an apple, but there are all sorts of types of apples. The other ones which we use for cakes, ones which we use to just eat directly, and that might be a useful comparison. So thanks for that.
Thanks.
I think, Leszek, your final comment slide was great, which summed up very nicely that they are similar, but they are not the same. So we still have differences, though there are a lot of similarities between the agents, but they still are not the same. And we have to, learn a lot of things. We still need to learn a lot of things about them.
Thank you.
Dr. Krishna, your comments.
So I think, till the Vertis CV came, we were talking about class effects. I think the class effect argument is now down the drain. So the way I would look at it is for everyone else, who does not have established ASCVD, then I think the field is open. But when you have established ASCVD, you really want to be using a drug for which there is data. So again, as a carryover from my talk this afternoon, I think, sometimes we get overboard about the CVOT bit. The majority of our patients do not have established cardiovascular disease, and therefore there's a field of comfort to choose from any of these drugs. But if someone needs a drug that specifically works in terms of protecting the heart, then you must choose the one for which the data is. The truth is that there are lots of ifs and buts about it. But given the scenario, I would, in someone who had established ASCVD, I would choose a drug that has a proven benefit in it, and for primary and for all the others to reduce glucose, to get the weight down, to get other desirable effects. I would choose any one of the drugs at this point.
Thank you, Dr. Krishna. Now, Sanjeev, you can start with the next session. With the next talk.
Yes.
Thank you.
Thank you, Leszek.
Thank you. Thanks a lot. Thank you.
Wonderful presentation and excellent question answer session we had. Now
Leszek, you can stay here with the
We need Dr. Leshek to stop sharing.
Yes, yes.
No, not
Oh,
Dr.
yes, yes,
Leshek,
yes,
the
yes,
other.
yes.
No, not you. I think Hardik,
Yes,
Oh,
Dharmender is sharing. Dharmender,
I'm
you please share
I'm
the.
sharing. Yes,
Yes, yes. So next talk is by
uh,
our close
Dr.
friend
Sanjay
Sanjay
Kalra.
Kalra. Yes, yes, yes. Everyone knows him very well. Sanjay Kalra is from endocrinologist from Karnal. He is President, Endocrine Society of India, Vice President, South Asian Federation of Endocrine Societies, Education Editor. Oh, cannot read. Yes, Education Editor, International Society of Endocrinology, and Section Editor, Endocrinology API Textbook of Medicine. Above all, he's a very good friend, a very good mentor for all of us, and a very good speaker. It's all yours, Dr. Sanjay Kalra.
So now you can share.
Yeah.
Yes.
Thank you, everybody. It's really nice being part of this gathering. Uh, it's good that technology is able to get us together. I am able to meet Dr. Krishna after so many months and Dr. Leshek after more than a year. We'll speak today about hypoglycemia and cardiovascular events. We'll also talk about, we'll,
So you have to share again, I
I
guess.
think, yeah. We'll also talk about various aspects of diabetes care and we'll keep it a free-flowing discussion. Please feel free to interrupt or to ask questions or raise a hand whenever you feel like. Now, we talked about mangoes, and mangoes, even just thinking about mangoes makes you hyperglycemic. And that must have been the reason why, for many, many years, many, many decades, hypoglycemia was perhaps a neglected complication. When I was a student in endocrinology, many of our professors used to say, if you have a type 1 diabetic who is admitted in the ward, you must cause hypoglycemia at least once so that the person understands how hypoglycemia feels like. And that used to be part of training in many centers across the country. Mercifully, mercifully for the patient, those are days of the past. And now we actually try to keep peace with diabetes and also with hypoglycemia. The Panchsheel, or the five principles of peaceful coexistence, and because of the current political situation these days, these are very important for India. Uh, just like you need to coexist peacefully with your neighbors, you also need to coexist peacefully with diabetes. And the glycemic Panchsheel model tells us that while we try to achieve a good fasting, a good postprandial, and a good A1C control, we must also try to minimize glycemic variability and minimize hypoglycemia. If we are able to have this Panchsheel, life is much easier for us. A more sporting kind of an analogy comes from the glycemic sixer. So as an all-rounder, we need to be a good batsman, and also we need to know how to handle every kind of ball that comes to us. A good batsman is the one who is able to, score fours and sixes off every ball. So whenever you prescribe a good glucose lowering drug, you want to score fours and sixes. So you want good fasting and postprandial control. At the end, you want a good A1C. But suppose you get out, then what's the point? Even the best batsman in the world will not be able to score once the bowler has got him out. So while achieving good control, we also want to minimize hypo, nocturnal hypo, and glycemic variability. So in the concept of glycemic sixer, we have three action-oriented goals, but we also have three caution-oriented goals. When we want to be cautious, we have to be careful, and we should know the definitions of hypoglycemia. The definitions of hypoglycemia, especially the classifications, have changed, and you will find that there are multiple classifications. This is the simplest one that is used in most clinical trials. Pseudo-hypoglycemia is when there are symptoms of hypo, but there's no biochemical documentation. Or the biochemical documentation is actually that the glucose is above 70 milligram percent. If you have symptoms suggestive of hypo, but there's no documentation, the person could not get a glucose level checked, that's probable symptomatic hypo. Hypo will be defined as a glucose less than 70, and it can be symptomatic or asymptomatic. But if a person needs the assistance of another person to come out of hypo, even if the other person is offering some food or some drink, that is defined as severe hypoglycemia. We need to know how to measure hypoglycemia, how to measure glucose. Otherwise, we can't improve our quality of life. And this was told to us by Lord Kelvin, who's the originator of the Kelvin scale for temperature. And when we assess, when we check, when we quantify, we actually find that hypoglycemia is the critical limiting factor in effective glucose management. If we get into hypoglycemia, if we are not able to coexist peacefully with that glycemic punch shield model, we end up incurring greater costs and we reduce the quality and quantity of life of our patient. Why does this occur? This occurs because hypoglycemia leads to multiple physiological or so-called adaptive changes in the body. It acts upon the heart, which is the myocardial pump. Within the heart, it leads to hemodynamic changes, and also it can cause arrhythmias, various types of arrhythmias. Apart from acting on the heart, it also acts upon the vasculature. It will act upon the microvascular organs, specifically the brain and the eye, and then it acts upon the vascular bed, the vascular tree. What does it do to the vascular tree and to the blood that is circulating in the vascular tree? To the vascular tree, it can cause endothelial dysfunction. It can also cause inflammation. And to the blood that is circulating in the vascular tree, it can cause blood coagulation abnormalities. So you find hypoglycemia acting throughout the circulatory system, throughout the cardiovascular system. It acts at the target organs, the macrovascular like the heart, the microvascular like the eye and the brain, and it acts at the entire vascular bed. It acts at the wall of the vascular bed and also at the blood that is flowing through this vascular blood. Does this mean that we should be afraid and we should not treat diabetes? Certainly not, because this African proverb tells us that if you can see the snake won't be able to bite you. So if we know what hypoglycemia is, we can prevent ourselves from suffering from hypo or from suffering from the adverse events of hypo. We must measure, however, we must keep on checking, because it is generally thought that hypoglycemia is not reported commonly enough, especially in type 2 diabetes. Sometimes the symptoms of hypoglycemia are so non-specific that people confuse between hypo and other diseases. For example, anxiety neurosis, or maybe a hot flash, unstable angina. All these have symptoms which are quite similar to those of hypoglycemia. But when you put patients in a good trial, you find that actually hypoglycemia occurs. And in these old trials, why I say old is because the drugs that were used in type 1 diabetics who participated in DCCT and in type 2 diabetics who participated in UKPDS, these drugs are routinely not used in practice now. With the older insulins, with the older sulfonylureas, we actually found that you could achieve good intensive control. You could reduce microvascular complications significantly. You could reduce macrovascular complications to some extent, but you would have to pay the price of hypoglycemia, of an increased risk of hypoglycemia. And the average percentage HbA1c at which the payoff seems to go negative is when you try to bring the A1c below 7 or maybe 6.5. But remember that these are older sulfonylureas, older antihypertensives, older insulins that were used in these trials. Let's look at the newer trials. When we look at trials that have been reported maybe about a decade ago, we find that the hypoglycemia was associated with increased mortality. But in ACCORD, hypoglycemia occurred in the intensive arm as well as in the conventional arm. Hypoglycemia may have been associated with increased mortality, but it did not cause increased mortality. What the authors felt, not author, but authors of all these studies, what they felt was that severe hyperglycemia is actually a biomarker of high risk. So people who are at risk of severe hypoglycemia are also at risk of other diseases, other complications, and that is why they have a higher mortality rate. One of the aspects which has not been studied in all these trials is cardiac autonomic neuropathy. Now, when we look at the study design, the trial design of the various trials that we all read, so many things, all the various permutations, combinations are taken into consideration while designing the inclusion criteria, while designing the primary, the secondary, the tertiary, the exploratory endpoints. But cardiac autonomic neuropathy is always missed out. And actually, it is CAN, which is a bridge between macro and microvascular complications. It is also a bridge between hypoglycemia unawareness and hypoglycemia. And it is possible that people with hypoglycemia unawareness with cardiac autonomic neuropathy may also have uh, other cardiovascular dysfunction, which may predispose them to death. Similar results have been seen with the other trials also, even the trials which were not focused specifically upon glucose lowering. For example, the bezafibrate infarction prevention study. When we look at CGM studies, what we find is that hypoglycemia is actually associated with angina and it is associated with uh, arrhythmia. So hypoglycemia is arrhythmogenic. Hypoglycemia is anginotropic. It precipitates angina. Hypoglycemia is also an anginal mimic. It can mimic angina. So we must be aware of both these things. Overall, what we see from the various landmark trials using the newer drugs is that persons with long duration of diabetes, with a previous history of hypoglycemia, and with impaired renal function are at greater risk of hypoglycemia. Also, those with an irregular lifestyle or dietary pattern are at risk of hypo. What do we do? When we know these risk factors, what we do is we go a bit slow. Do not aim for a swift reduction in HbA1c. Do not aim for a stringent HbA1c target. Play safe, use drugs which are safer, and keep on assessing the risk of hypoglycemia at regular intervals. And like we said, when you look at if we see this slide in front of us, what we see is that with intensive strategy, as the HbA1c comes down, if you look at the right lines, and as you move from right to left, you see that the HbA1c comes down, the mortality also goes down, but the risk of hypoglycemia can go up. And the ideal trade-off will be achieved at an HbA1c of around 6.5 to 7, where you will have a low risk of hypoglycemia and also a low risk of death. It is also reported that the greater the HbA1c, the worse the hypoglycemia, the more the mortality. So we should bring glucose down, and as and when required in a particular patient, we should not shy away from intensive therapy. Of course, the safety net should always be there. We should aim for euglycemia, but we should aim for euglycemia in a safe manner. We did speak about DCCT and the older types of insulins. When we look at the newer types of insulins, the DEVOTE trial, for example, compared degludec with glargine. And what they found was that both were CV safe. There was in DEVOTE trial a difference in terms of hypoglycemia. Degludec had less nocturnal hypoglycemia. It had less severe hypoglycemia. But the CV outcomes were the same. This is another data set which tells us that hypoglycemia may not be associated directly with adverse CV outcomes. Like we said, they are biomarkers. Hypoglycemia is a biomarker, and it may be a biomarker of other comorbid conditions which can predispose to CV death or overall death, all-cause death. Chance favors the prepared mind. And if we are prepared with the risk of hypoglycemia, we are prepared with knowledge of whatever drugs we have available, we can actually do a good job of helping our patients. One way in which we try to help our patients is by prescribing the best possible OADs. And there has always been debate about the newer sulfonylureas as compared to the older ones. So in DEVOTE trial just now, we showed that the newer basal analogs are extremely CV safe. What about the newer or the new generation of the modern sulfonylureas? UKPDS had used the older types of sulfonylureas, which are not available in India anymore. When glimepiride was compared with linagliptin in the Carolina trial, they found that glimepiride was associated with greater hypoglycemia. But the CV outcomes were the same. So these authors, and this particular paper was presented at ADA last week. They set out to discuss the association between severe hypoglycemia, documented hypoglycemia, and CV outcomes and mortality outcomes. When they observed the data, when they analyzed the data of the 6,000 plus participants, they found that HbA1c was similar in both groups. Hypoglycemia was more in those with glimepiride. But when they compared hypoglycemia versus when they compared patients without hypoglycemia versus those with hypoglycemia, they found that hypoglycemia occurred more in the elderly. It occurred more in those with impaired EGFR, those with increased albuminuria, and those perhaps with a greater A1C, with a lower A1C in the patients on glimepiride. For linagliptin, they were not able to find any difference. So basically, the high risk factors for hypoglycemia could easily be identified in patients who were receiving glimepiride. Basically, the elderly patients, those with multiple CV risk factors, and those with impaired renal function. If we are able to understand this, then we will of course avoid sulfonylureas in such patients. In the elderly, those with a long duration of diabetes, and those with poor renal function. Hypoglycemia was associated with the increase in all-cause mortality and increase in non-CV death, but it was very clearly shown that these CV events were not caused by antecedent hypoglycemia. The same patient had a bad CV outcome. The same patient may have died. The same patient may have had hypoglycemia, but these did not occur together at the same time. So hypoglycemia did not cause mortality. It was associated with mortality. This is what the data says. Let me share what I do in my clinic. Whenever I have to decide whether what kind of an insulin I have to prescribe, what kind of an oral drug, what my approach should be to the patient's glucose control, I try to help define the patient's glycemic personality. Now, we all know what personality means. Our chairpersons today, for example, have a handsome and smart personality. Physically, mentally, emotionally, socially, their characteristics are such that they're the leaders in the country. To add to this, if we add the glucophenotype, that means the glucose, that gives us the glycemic personality. Glycemic personality can be classified as biomedical as well as psychosocial. To understand the personality, I use the mnemonic SURE, S-U-R-E. In the glycemic sixer, we had 3 action-based endpoints and 3 caution-based. Here also, SURE is divided into 2 action and 2 caution points. S is for severity and style of hyperglycemia. This will help me define, choose my therapy. U is for urgency and utility of glucose control. In some patients, glucose control may be urgent if the patient has a pyelonephritis, for example. In others, there may be no utility. If the patient has a CA pancreas with metastasis all across the body, there's no point in improving glucose control beyond a particular level. The maximum I can hope to do, the maximum I should try to do is to relieve osmotic symptoms, not more than that. R is for risk of hypoglycemia, and this is very important. If I have a patient who is at high risk of hypoglycemia, I should go slow. Somebody with irregular diet or physical activity, somebody who takes a lot of alcohol, someone who is elderly. 3 points. Renal dysfunction, hepatic dysfunction, gastrointestinal dysfunction. 3 medical points. Hypothyroid, hypoadrenal, hypopituitary. 3 endocrine points. If I look at these 9 points, I can actually be very safe when I'm prescribing therapy. E is for expected adherence to therapy and also expectation of the patient. So the patient defines how aggressive I will be. Once I've done the glycemic personality and I've prescribed a particular treatment regimen, then this is something I follow in my clinic. It is called the Hypoglycemia Awareness Questionnaire. 12 simple questions with which we take a history suggestive of hypoglycemia. I personally administer this questionnaire to all my patients on intensive insulin and also on high dose sulfonylurea. And these questions are so simple to do. It would be nice if the organizers could share this with all the audience and try to translate this into your own language, whether it's Gujarati or Haryanvi or Malayalam or Telugu. You will really enjoy translating this into your language, and then you will enjoy speaking about this with your patients. To conclude, we were to talk today about hypoglycemia. Hypoglycemia is a critical limiting factor in effective glucose management. It is associated with significant costs and worsening of quality of life. We should try to bring HbA1c down. We should worry about hypo, but hypo directly will not cause bad CV outcomes. It will be associated with CV outcomes. If we can identify the high risk cohort, then we just go a bit slow. My last slide, we can easily achieve Vijay over diabetes. And that's by the following 5 V's. By following the following 5 V's: Vyayam or exercise, Vyanjan or diet, Vyavhar or good behavior, Vyakul Vichar or stress management is something that's very important. And the fifth one, we request all our patients to do Vaidya Anupalan or adherence to therapy. If we do all these 5 V's, we can easily overcome the virasat and the vatavaran that we have, and we can achieve the right vidhi that God has planned for us. Thank you.
Thank you, sir. It was really a nice and lucid presentation, taking us from the journey of how we can tackle hypoglycemia and a practical approach how we can develop. It was really nice to see your SURE model, and also thank you for giving us hypoglycemia awareness questionnaire. Thank you, sir. So if we have, do we have any question, Dr. Rutul?
No, I'm not seeing any question, but definitely you can ask.
Yeah, one thing which I just wanted to know from you, sir, is there any sort of some point-based system or some risk score for the hypoglycemia which is there or which we can be developed? Because as we have the many risk factors, so is there any sort of which can make it more simpler for the primary physicians?
There is no objective or no validated score. So the two things which I have mentioned, these are the best that we have been able to do. Once you have begun treatment, then monitoring is done by the hypoglycemia awareness questionnaire. That questionnaire can also be used for risk stratification. If you have somebody who is answering yes to most of the questions, he or she may or may not have hypo, but the symptoms are suggestive of hypo. So don't be too aggressive. That is like a batsman who has come on a pitch. He is not able to read the pitch properly, so he will be defensive. And after a few overs, then maybe he can become offensive. To all the primary care professionals, when you are handling acute disease, like let us say malaria or dengue fever or COVID, then everything has to be done in cross-sectional terms immediately. But when you're handling diabetes, you can always do it in a longitudinal way. If the patient has diabetic ketoacidosis, then all the action has to be done today. You cannot wait until tomorrow. But for routine diabetes, we can always wait. So if you cannot read the pitch, go slow. Hypoglycemia awareness questionnaire will help you read the pitch.
Fine, sir. Thank you.
And otherwise, the SURE model is something we spoke about. And if you remember this 3x3 rubric, 3 endocrine points, 3 medical points, and 3 general points, which was the elderly, alcohol intake, and irregular pattern. These 9 points, I think, should help us give a fair idea of the risk of our patients.
Great, sir. Thank you very much.
Thanks.
Thank you. Thank you.
So we don't have any more questions. We can move forward for the next session and would request our chairperson, Dr. Rutul, to introduce our next speaker.
Yes. So we have next session from Dr. B.M. Makkar. He's from New Delhi, and he's director of Dr. Makkar's Diabetes and Obesity Center in New Delhi. He's honorary secretary of RSSDI from 2017 to 19. Just last year he left it, and he was ex-chairman of RSSDI Delhi chapter, member of executive board Diabetes India, honorary secretary of Indian Obesity, member of ACE International Committee 2014, 2016 to 17, and ACE Professor Business Committee
and international work exposure of UCSF San Francisco, Cleveland Clinic, and John Hopkins and Oxford Diabetes Center, and also Mayo Clinic. He's a course director for Cleveland Clinic Advanced Certificate course in diabetes from 2010. And he has many publications, books, and national and international journals. So I'd like to request him to start his session. I'm stop sharing my screen and I request him to share his screen. Thank you very much, sir.
Thank you, Rutul, for a very kind introduction. Am I audible?
Yes, sir.
Okay.
Perfectly.
Can I share my screen now?
Yes, sir.
Okay. So, is this okay on your screen now?
Yes, yes, sir.
Great. So, good afternoon, everyone on the other side listening to this presentation. I think it's a great meeting that's going on since yesterday, and I've been glued to so many sessions that I have, attended during last 2 days, and the content and the speakers, everything has been phenomenal. And I must thank my dear friend Bansi Sabu for giving me this great opportunity and involving me in this program. So my topic here is fatty liver in busy clinical practice, and I'll touch upon some management issues and how we should go about that. I don't have any disclosures for this presentation. So the presentation layout is that I'll be briefly speaking about fatty liver. What do we know about this? What we actually see in the real world scenario, what are the management issues in busy practice, and what we should do about it. So first thing is fatty liver. Fatty liver or NAFLD, which are the words are used synonymously, though they are not synonymous, is characterized by excessive fat accumulation associated with the insulin resistance in liver, and is defined by the presence of steatosis of more than 5% of hepatocytes according to histological analysis. Or this may also be defined as proton density fat fraction of more than 5.6% assessed on the proton MR spectroscopy. Now, NAFLD actually comprises of two very distinct and pathophysiologically distinct entities with different prognosis. One is the non-alcoholic fatty liver, which includes only pure steatosis, that is fat accumulation, or fat accumulation with mild lobular inflammation. And the second component is NASH or non-alcoholic steatohepatitis, which includes a wider spectrum of involvement of liver ranging from very early or almost no fibrosis progressing to increasing fibrosis, ultimately progressing to cirrhosis and increased risk of hepatocellular carcinoma. Now this slide just shows you that NAFLD is a continuum, and it progresses from normal liver to gradually to NFL, NASH, and finally cirrhosis. And what we know about all this is that this progression takes a long time. From normal liver, there is a deposition of fat, progression to NASH, fibrosis, and ultimately cirrhosis and hepatocellular carcinoma. But some of the patients may not develop cirrhosis and directly go on to develop HCC. Now, important thing here is the first part, that is before the development of fibrosis, this can be a reversible phase. This is the phase of fatty liver or early fat NAFL, which we should recognize and act. Because we have to identify this early, one, because once there is fibrosis, it is going to go on progressing, and as the fibrosis progresses, there is decrease in the survival possibility or increase in the mortality risk. And if you look at this slide, as compared to patients who do not have any NAFLD, there is markedly increased mortality related to liver-related disease, cardiovascular disease, or overall mortality in patients with NAFLD, and it is further increased in patients with NASH. And please note here that there is not only increase in the liver related mortality, in fact there is a significant increase in cardiovascular mortality also. Now we know that NAFLD is a big problem. There is a high prevalence globally, and it is estimated that 25% of the world population has some degree of NAFLD. Studies in India suggest that we have anything between 10 to 30% of the general population in India who's having high prevalence of uh, NAFLD. This was the first population-based study from Chennai from Dr. Mohan's group, and they looked at the prevalence of NAFLD in urban South Indian population, its relation to dysglycemia and metabolic syndrome. And what they showed was that 22.5% of the people with normal glucose tolerance had NAFLD, while it was 33% in patients with pre-diabetes and more than 50% in patients with diabetes. And if you look at this table, not only it was the dysglycemia which has strong predisposition for NAFLD, there was a strong association with obesity, abdominal obesity, components of dyslipidemia, and metabolic syndrome. What happened? I think there's something went wrong. Okay. So study concluded that NAFLD is present in about a third of Asian Indian population in South India, and it's increasing. The prevalence increases with the increasing severity of glucose intolerance and metabolic syndrome. This is another study which looked at various clinical parameters and insulin resistance and showed that possibly central obesity and insulin resistance are two key underlying pathophysiological defects in patients with NAFLD. Now we know that India has a very high prevalence of diabetes, with more than 77 million diabetes patients in India, and we Indians also have a higher insulin resistance as compared to Caucasian population. Not only this, even Indian children have been shown to have very high degree of insulin resistance as compared to other populations in the world. And we also know that we have a typical Asian phenotype, which is characterized by central obesity, less of peripheral fat, low lean muscle mass, and high risk for developing cardiovascular disease and metabolic syndrome. Now, if you look at the NAFLD and cardiovascular disease, they both have common metabolic risk factors such as obesity, diabetes, and hypertension. And though there are common, associations, the studies have also shown that NAFLD is also independently associated with cardiovascular disease if we take care of the confounders. Cardiovascular disease has been shown to be the most common cause of death in patients with NAFLD. Now, this was a very recently published study from PGH Chandigarh. They looked at prevalence of fatty liver NAFLD in healthy male voluntary blood donors, and basically it was an ultrasound-based diagnosis, and they found that almost 55% of the patients had fatty liver on ultrasonography. So this shows that we have a high number of people in general population who have fatty liver disease. And the study also showed that age, BMI, increased waist circumference, high systolic blood pressure, increased total cholesterol, and number of components of metabolic syndrome all were independent predictors of presence of NAFLD. So NAFLD is the most common cause of liver disease worldwide. It affects almost 20% of the general population, or 1/3 to 1/2 of Indian adults have some degree of NAFLD, as we are seeing from the recent studies. The important thing is, though we know all this, the prevalence and incidence of recorded NAFLD diagnosis in real world situation is practically unknown. So let us see what we find in the real world scenario in clinical practice. So I couldn't find any studies on the diagnostic prevalence or the levels of NAFLD in the primary care practice in India, but this was a fantastic study which I found from BMJ Medicine. This is a study which looked at harmonized health records from 4 major European countries: UK, Italy, Spain, and Netherlands. And this assessed the age and sex-specific point prevalence and incidence of NAFLD from primary healthcare databases of these 4 countries. The study involved 17.7 million adults, of which 176,000 had recorded diagnosis of NAFLD. Comparing between 2007 and 2014, the prevalence had increased from 0.6% to 1.85%. So if you look at the prevalence of NAFLD in this study was very, very negligible, and it's only 1.85% in 2014. The incidence doubled from 1.32 to 2.35 per 1,000 person years in 2014. And they also looked at the 4 non-invasive estimate of liver fibrosis and could calculate that about 30% had intermediate or high-risk scores for liver fibrosis. There was no difference in this prevalence in sexes, and there was increased prevalence in the higher ages, more than 60 years. Now, if you look at the gaps in the data that we have from very controlled or scientific studies, then the data we have is that by imaging we know that there is almost 24% of people who have NAFLD and almost 13% by blood tests. And if you look at the pooled prevalence from this European database, only 1.9% were having NAFLD, which is at best 1/6 or 1/12 of the estimate from the studies that we have. So what we are seeing is that there is underreporting of the data or the underdiagnosis of this entity in clinical practice. So there is a large shortfall in Europe between the expected numbers and the numbers recorded in diagnosis. And there's a huge diagnostic gap in 4 European territories. And this under-recording of NAFLD in primary care may reflect that there are missed opportunities to make diagnosis by investigating abnormal liver enzymes or imaging, a lack of confidence to make diagnosis even if the enzyme reports are available, or under recognition of the diagnosis in secondary care. Also, there is a factor that a lot of people take alcohol, and those who are taking alcohol, whether you have to label them NAFLD or no, again becomes a question. So this is another small study from Dutch database, Dutch physicians, a recent survey of Dutch general practitioners, which looked at the attitudes of how they gave importance to NAFLD, and they found only about 47% of doctors used liver tests patients who had NAFLD, and non-invasive scores were never used by almost 3/4 of the physicians. So moral of the story is that NAFLD is significantly underreported or a significant misdiagnosis in real-world clinical practice. Now, if you look at the management issues in busy clinical practice in India, Indian scenario is very, very different. In primary healthcare, we do not have any data. Data is virtually non-existent, even in the physician level practice or the hospital care practice also. Healthcare is largely private practice, which is out-of-pocket payment. So that complicates the issue because finance becomes a challenge, and India is not a very rich country. We have largely poor or lower middle income patients. Large number of patients are there for every physician in the clinical practice. So only limited time is available per patient, and the attention cannot be given to minor details. Second thing is, if you advise additional investigations, it costs additional money. So increased cost becomes a challenge when patient has to pay out of pocket, and patient's only concern is that please treat my primary problem. I'm not willing to go for any further investigation or treatment for other illnesses which are possibly silent problems and may not have any harm in long term. So NAFLD is very, very likely to be missed in physical clinical practice in India also. So what should we do now in such situation? We have to identify the risk factors. If somebody has diabetes, obesity, dyslipidemia, metabolic syndrome, and so on, we should look for NAFLD. AASLD recommends that in type 2 diabetes patients suspect NAFLD and NASH and determine patients' risk for advanced fibrosis. And if there is increasing number of metabolic diseases, there is increasing risk of progressive liver disease. ESL, ESD, ESO recommendations are that NAFLD screening is recommended in persons who have high risk of CVD, those including metabolic syndrome and type 2 diabetes. ADA recommends that patients with type 2 diabetes or pre-diabetes with elevated liver enzymes should be evaluated for presence of NASH and liver fibrosis. Now, what are the current strategies for identifying NASH and fibrosis? I will not go into the various technique or details. Now, important thing to keep in mind is that there is no single investigation which gives you a diagnosis. Measuring liver enzymes has its own problems, and AST, ALT values may not be very sensitive parameters to diagnose NAFLD and NASH. Similarly, ultrasound and CT scan cannot identify most of the NAFLD stages or severity. They may be, ultrasound may be helpful in picking up fatty liver or advanced cirrhosis, but not all the different stages. Similarly, CT has limitations. The only gold standard is liver biopsy, but it has its own limitation because it involves an invasive procedure, risk of bleeding, cost, and you may need to repeat to evaluate the patient, and so on. So because of this, we have some newer strategies which have got devised, and there are some serum-based scores which include liver enzyme parameters, platelet count, BMI, albumin levels. And because based on these scores, you can have a good negative predictive value for ruling out liver fibrosis. Their calculators are available freely on net. Most common parameters used for scores are age, AST, ALT, platelet count, BMI, albumin, and dysglycemia. And you can see there is an NAFLD score and a FIB-4 score, which are commonly used. There is FibroScan or vibration controlled transient elastography, which can be used, which is the point of care equipment, does not require any specialist to run the test and can rule in or rule out advanced fibrosis. But the cost is a limitation as of now. This is a good tool for ruling out the advanced hepatic fibrosis, but can overestimate fibrosis otherwise. MRI can be used. Again, the cost is an issue. Now, important thing here is we have the huge number of options what we can do. Important thing is we need to customize according to our practice, the kind of patients we see, the kind of facilities we have available, and the kind of cost patient can afford, and what is required for a particular patient. To bring it all together, the non-invasive serum tests and scores can reliably exclude advanced fibrosis, while non-invasive elastography is important to confirm the fibrosis. So you can choose between what you need to do. Second thing is, there is a school that says that since there is no treatment for NASH, so you don't need to diagnose it. The approach is wrong because lifestyle interventions have been shown to improve fatty liver disease in the early stages, and there can be reversal of fatty liver to normal liver with the moderate weight loss, modest weight loss, and good dietary behavior and exercise. And bariatric surgery has been shown to improve NASH and NAFLD. Globally, there are no approved drugs, but India has the first approved drug for NASH, which is saroglitazar. And other drugs like metformin is not recommended. Pio is recommended, but should be used only in patients with NAFLD who have biopsy-proven NASH. GLP-1 RAs are being studied for same, and so is the situation with SGLT2 inhibitors. Vitamin E has been recommended, but again, there are issues. It is not recommended for NASH in diabetic patients or NAFLD without a liver biopsy or cirrhotic patients. Saroglitazar has been approved on the basis of evidence 2 trial, which showed that saroglitazar brings down the liver fat, improves the liver enzyme, and cuts down the disease activity in liver. There are a number of drugs which are in study, but as of now, we do not have anything in hand. There is something called obeticholic acid in NASH, for which the papers have been submitted to FDA for approval. Let's see what happens. So to sum up my presentation, NAFLD NASH is growing rapidly, not only globally, but also in India. NAFLD is more prevalent in people with obesity, insulin resistance, diabetes, and very common in Indians. NAFLD has become a leading factor for liver transplantation, and is not only associated with liver-related mortality, but also with increased cardiovascular mortality. Early recognition of NAFLD is important, especially the fatty liver, to prevent NASH, cirrhosis, and hepatocellular carcinoma. Lifestyle intervention and weight reduction should be given primary focus when you come across such patients, and drugs like saroglitazar and pioglitazone may be of some help, or in morbidly obese patients with NAFLD, bariatric surgery can be advised. Thank you. Thank you for your patience, and I think I am happy to take any questions if there are there.
Yes, sir. There is a question from Dr. Harsh Hirani. How do you plan dosing of ursodeoxycholic acid based on confirmed graded fatty liver by USG or elastography? Also, is there any biochemical parameters based criteria to predict the grading of fatty liver based on lab values of liver function test?
So, first thing is UDCA is not an approved medication for treatment of fatty liver. So I don't know anything about how you choose the dose, about the grading. Second thing is about the grading based on the lab values. There are some studies which have shown that if you have the ALT and AST ratios calculated, they can be helpful, but they are again still not very much validated.
Okay. Thank you, sir.
One more question is there. Where would you put usefulness of NAFLD fibrosis score in your clinical practice?
Which score?
NAFLD fibrosis score.
So these are two scores which I showed you in my presentation. One is you can choose any score, and you can actually have calculators downloaded to your phone. They are helpful, but important thing is they will be helpful only if you have early disease. Once you have and not diagnose these patients early in the course of disease, or you are not looking for diagnosis of these patients early in the course of presentation, when actually they don't have any symptoms of NAFLD. So practically anybody who is obese and diabetic walking into your clinic, you have to suspect NAFLD.
Right.
So what you need to do is, basic requirements is, one, do a clinical examination. If you feel liver edge is there and firm, you suspect NAFLD. Second is ultrasonography, which can be advised to large number of these patients. A non-invasive test, not very expensive. Third is the liver enzymes. If they are increased, again you suspect this. If you have diabetes, you have dyslipidemia, you have hypertension, you have metabolic syndrome, all these are candidates for suspecting this. So once you suspect this, then you can use these scores to define whether these patients have high risk for fibrosis. If you have high risk for fibrosis, you can screen them further with FibroScan.
Thank you, sir.
So we have next and
Thank
last
you
session.
for very much for having me here, and good afternoon, good evening, Krishna. Over to you.
Yes, we have next session from Dr. Krishna Seshadri, and he'll be talking on pharmacogenomics in diabetes medicine, how close and how far we are. So over to you, sir.
Thank you. I'm bringing up the rear of this conference, and hopefully, the one nice thing is you don't have to go take a long ride back when you leave it. So hopefully we still have a few people besides the chairperson listening in. When she talked to me about this, I actually put up a picture of Casper the Ghost, because this is really an area that is so much in flux. We're not so sure. By the way, am I audible?
Yes, sir.
area is so much in flux that it's so difficult to talk about this because it's evolved over a period of time. Interestingly, what is this whole thing about? I think it's important to remember that what we are talking about is what is causing the variations in dosage, variation in response, and variation in the adverse effects that occurs in common medications. Initially, this was done through a genetic mechanism that was through a candidate gene approach. And now we have the advantage of having GWAS and others. But as I can tell you, this is far more complex than everyone would like it to be. And it's nowhere near where we want to bring it into clinical practice. Unfortunately for diabetes, this has happened. Although in many other areas, you will see, and I'll give you the exception in diabetes, you will see that this pharmacogenetics or pharmacogenomics has taken a big stride. For example, with use of warfarin, with use of abacavir, where the stakes are high, where the adverse events are high, these have taken big strides. What is the framework of pharmacogenomics? So one, there is a variation in efficacy and treatment, and this could be due to pharmacokinetics or pharmacodynamics. The pharmacokinetic variation is due to the genetics of drug transport and metabolism. The pharmacodynamic variation is because of the genetics of diabetes risk itself and the genetics of the target receptor or organ that is being studied. Unfortunately, again, as I said, this is such a simplified explanation that there are much more things that affect the drug other than just the gene expression. Therefore, unless it's available in front of you, many of the time it may not be useful to obtain. The one big thing that we know, and this is the reason why precision medicine is such a big thing in diabetes, is the discovery of the MODY genes. And remember HNF1A, and of course, this particular one, the KNCJ11 and ABCCA, which are part of the inwardly looking potassium channel and the SUR1 receptor, have pretty much identified subsets of patients who don't require insulin, right? And who can be taken on medications. On the other hand, you have these people who are type 1 diabetes, who have mutations in the HLA region, insulin region, and the PTPN22 region. All of these require insulin. On the other hand, there are other parts of things, for example, TCF7L2, which sort of reduces the action to some of these drugs, right? So, given the drugs that are available, we know of some ways that the pharmacogenetics affect them, right? We know, and this is through the candidate gene approach. We know about metformin, which is the best study. We'll talk about this a little more. We know something about sulfonylureas, especially the ABC88 and KNCQ11 gene. Some things about the thiazolidinedione, and of course, a lot of things about meglitinides, a drug that is not very much used in our population. As I said, monogenic diabetes is one very example of precision diabetes, you know, and it's also interesting because you do some reverse engineering and look at things to figure out other things. From a clinical point of view, we know that some of these, for example, HNF1A is involved in CRP mechanisms, or low CRP is in fact one of the pointers towards a MODY diabetes. But it's important to understand that at least in this particular area, we are already in the era of precision medicine. Metformin is an interesting example, and if you look at this carefully, it functions through several transporters. It's not metabolized in the body. It's taken up by this particular one called OCT1, right? And then from the enter side, it's taken into the blood by OCT1, and then it goes into the bile through OCT1 and is excreted in the urine by OCT1. And OCT1 is the one that's very much studied. And one of the and the gene that, and the variation that encodes for it is an SLC47A1. What we know is that if you have one of these metabolites, and if you are a homozygote, and let's say the variations are there, then there's an increase in metformin intolerance, and of course the lowering of metformin efficacy. But the interesting question is, you know what? If I want to find metformin intolerance, start the drug, And if they have a GI discomfort, remove, I'll stop the drug. So the stakes are very, very low. Another interesting thing is, of course, is that just the presence of one of these does not necessarily mean the patient is going to have metformin intolerance. For example, the gut microbiota is a very, very important determinant of metformin intolerance. Also, when one of these becomes more, there is also an overexpression of the other. For example, the MATE2K pathway. So these candidate gene hypothesis and the candidate gene, methodology pretty much does not look at how these interact. And the truth is that the genes seldom are an important part, just one part of the whole thing. There are many other things, including the environment, other proteins, the presence of other variations or SNPs that make it happen. So it's important to understand that this is why we are not ordering more of these gene tests in our practices, right? But something very interesting is that one of the things that we know in the last couple of years is that metformin actually interferes with the cardiovascular benefits of SGLT2 inhibitors. Remember that what happens when you do an SGLT2 inhibition is activation of AMPK kinase and activation of SIT1 pathways that enhance autophagy and therefore promote the benefits. When you combine this with metformin, which actually works through the OCT1 and AMPK pathway, there's actually an attenuation of benefit. So at least we now know there is one or two things that we can look at it. Is there an OCT1 issue? When you have an OCT1 problem, does metformin not produce the effects? This is something that can be looked at. So there are some issues where traditional pharmacogenetics probably still has an impact. DPP4 inhibitors, again, we know that there are variations in response as the Asian subpopulation, mostly because of beta cell dysfunction, where DPP4 inhibitors actually do much better. On the other hand, if you look at this is TCF7L2 and NOR1, which are two genes that actually work towards either improving or reducing DPP4 effectiveness, right? So this is an overview of the pathways. I don't want to spend too much time on this, but what it tells you is that that many of these genes work at different levels and either improve the effectiveness of a drug or cause their adverse events. This is the summary of what we currently do. For example, with metformin, ATEM is looking at A1C reduction. SLC822 is looking at gastrointestinal adverse events. Sulfonylureas with KNJC11 and CYP2C9 look at A1C reduction. PPAR gamma looks at TZDs. With SGLT2 inhibitors, there is not much of evidence. But what we know is that since the effect of the GWAS, more and more of this has happened in the last few years. Not much in the public domain, but this is an area where there's an explosion that's waiting to occur. This looks at currently there are 463 genes or variations of genes which we call SNPs that impact the effect on diabetes. There's much more than what we knew a decade ago. But why is it that we don't have too many genes that we can measure, look at, and use in our practice? Look at what really happens is that the ones that have a very big effect size have a very small percentage in the population. On the other hand, what is present very commonly is usually has a very small effect size. For example, this is TCF7L2, whose total impact on the management of diabetes is very less, but it's quite common. On the other hand, if you look at the MODY genes, they are very rare, but their impact on management is very high. And also, there are lots of other issues, including methodology, in sequencing, in number size, the population that is studied, and these are the issues that people are looking at. So this includes testing, not easily available, and sometimes just starting the drug and taking it off is much more cheaper than ordering the test. Terminology is not standardized. It took me a while to figure out pharmacogenetics versus pharmacogenomics, and most of you would feel the same challenge. There are very few dose relating algorithms. lack of real world studies, lack of medication use data. Some of the databases are very poor. And of course, these are not really taught in medical schools. These are not part of symposia like these. For example, this particular topic comes at the rear end of a conference. There are other issues like ethical issues, privacy, and legal issues. Right? So how does this change? Is this going to be dead? No. There are new things that are going to occur. And there is a very, very interesting group of technology that has come into this that looks at what is called a system biology approach. One is the presence of jivas, what is derived from jivas that we are able to using a computer, using pattern recognition, map and annotate, and then look at, more importantly, what are the things that are really useful. For example, we now know that there are networks. It's not just a gene, but a network of genes that acts. And each of these can have a weightage and an expression that affects the expression and the work of the other. And by actually giving them orders and using machine learning and artificial intelligence, we will be able to identify clusters that really work. Some of you may remember the other clustering by using data, K-means clustering, which actually identified 5 different kinds of diabetes in people. So what you really want to do is to put these two together. In the clustering, they showed that there was one cluster that had a greater time to insulin, another had a greater time to metformin. So when you put these two together, you will find some genetic association tests that actually work towards each other. So while the traditional candidate gene approach pharmacogenetics may be dead, a new biology is emerging where use of EMR, big data, artificial intelligence, machine learning combines with good old-fashioned clinical intuition that will make this better. So this is where we are. I don't want to take too much of time on a Sunday evening where everyone's ready to actually go and get some rest on a very, very busy 2 days. Thank you for the patience. If there are any questions, I'm happy to answer. Again, thank you, Banshi, Hardik, and others who made this a wonderful, wonderful conference. Thank you so much. Appreciate this.
Thank you, sir, for your wonderful presentation. One of the unique topic and how it will be useful in future and its clinical application. Before we have another questions, just I have read somewhere in 2008 some paper from Sri Nair where they said that Indians people, or we have our skeletal muscles and mitochondria have higher capacity to produce ATP in comparison to the Caucasian. So whether there is any, it is something like dissociation between our insulin resistance and energy production likewise thing, or what exactly can be the pathophysiology, or what's your insight in that?
So this has been very well shown that, that not only while we have a higher ATP production capacity, we also have a lower exercise tolerance that has also been looked at. What is important to understand is, that just looking at a gene and its expression alone does not seem to matter anymore. You need to start to bring in everything else. For example, I talked about metformin. It's a great way to look at things. If you look at OCT1, it tells you, okay, this will predict that metformin will not work. But the truth is there are other things that may make metformin work. For example, what kind of food you eat, what is the gut microbiota. If OCT1 is underexpressed, is MAT overexpressed. So these are other reasons why drugs work and not work. The genes are only a small part of the picture. So far, what we have done is looked at the elephant from our own perspective. We have looked at, like how we had this debate in the morning. The cardiologists are looking at it from one perspective. The nephrologists are looking at it from the other perspective. You really need a holistic perspective. Similarly, I think drug discovery, pharmacogenomics, and each of these need to be looked at a broader picture of ultimately what is its clinical utility. That comes from pulling down patient data, looking at various ethnic differences, we're looking at the interaction with the environment such as gut microbiota or other things, and also the gene expression. When multiple genes interact, the risk is higher. But again, that risk is only part of the larger picture. I hope that explains this.
Yes, sir. Thank you, sir. And would again switch or hand over to Dr. Rutul if there is any question, or else say word of thanks for the session?
No, there are no further questions in any chat box or in our uh, question answer thing. We can close it down. Thank you very much, Dr. Krishna Seshadri sir, for wonderful explanation of everything. Thank you very much again.
Thank you, Dr. Banshi, and congratulations to the whole team. Thank you so much.
Thank you.
Thanks, sir. Thanks, sir. And thank you, Dr. Rutul, for chairing this session. Thanks a lot. So here we conclude the session and also day 2 of our Diabetes Virtual Congress 2020. Thanks a lot, all of you, all participants, all speaker, all chairperson for the great support for this conference. Thanks. Thank you, lot.